We are delighted to welcome our next presenters, Commander Hymer, Senior Injury Prevention Specialist in the National Center for Injury Prevention and Control Program Implementation and Evaluation Branch, Behavioral Scientist and Evaluator in the Division of Injury Prevention, and Ms. Willocks, Behavioral Scientist and Evaluator in the Division of Injury Prevention. Today, they will present on the Division of Injury Prevention funding for tribes, updates and plans for future funding. We encourage everyone to give their full attention as we delve into the information presentation. Let's make the most of the opportunity to further explore opportunities for funding the tribes related to injury prevention. So welcome. Thank you.
Thank you. And it's an honor to be here with you all this afternoon. I was thinking, I think the last time that I attended a TAC meeting in person was all the way back in 2019 before the pandemic. So it's really great to be here with you all. I'm going to talk a little bit about some of the work that's happening in our division and then transition over to Stacey to talk about some of our evaluation work. So if you could move on to the next slide. The vast majority of our tribal overdose prevention work in the Injury Center is administered by the Division of Injury Prevention's newly formed tribal support team. And so before I share about our work, I want to share a little bit about our team. Our tribal support team was formed and stood up on August 1st of 2023. So we're just about 6 months old right now. And I think for us, that was really a significant milestone. Prior to August 1st of last year, our tribal overdose work was administered by the state local tribal support team, which was a great team, but focused, both on states and tribes. So it's been really great to have a team dedicated to advancing injury and overdose work across our division and really across our entire center. With that, we also have a new team lead. So Michonne Mabry, she's back in the corner there. If you can wave, Michonne, is our new team lead for the tribal support team, and she is fantastic. The other thing I want to, before I jump into our values here, is talk about when I say our team, that's not just the tribal support team. So we also work very closely with our evaluation team, which is a sister team in our branch. Stacey is here with me today, but we really do work closely with our colleagues on the evaluation team. And while on paper, we really are two different teams, with our tribal overdose work, we do operate as one team. So, Stacey and our other colleagues from the evaluation team are really embedded and integrated in the work that we're doing. And we really do operate as one team. And our joke is kind of, if you ask Stacey and I to come and talk, you're going to end up with both of us like today. And that's because our work is so intertwined. So our team is really committed to empowering tribal communities to develop and shape the programs that affect them and encourage community ownership and participation. And so our approach is respecting and integrating tribal cultures and indigenous knowledge into our work. We listen, learn, and adapt to the unique needs of each of the tribal communities that we serve. So we fully understand that a one-size-fits-all approach really doesn't work with tribal overdose prevention. And I think that we accomplish that really by operating, kind of by some core values that are listed here on the slide. We promote meaningful collaboration with our tribal partners and respect tribal sovereignty, and also recognizing tribes and tribal epicenters as public health authorities. And, we've consistently heard that, from our tribal partners from the TAC, that culture is prevention. And so we support the inclusion of indigenous knowledge and reclamation of culture in the prevention of overdose, and are really intentional about providing that space for these activities in our funding that goes out to tribal communities. Next slide, please. So we are funding overdose prevention initiatives through three kind of categories of supplements to three different cooperative agreements. The first of those is the Tribal Epidemiology Center Public Health Infrastructure, or TECFI, cooperative agreement for the overdose supplement. And so this project is intended to improve overdose data for American Indian and Alaska Native people by working with tribal epicenters to improve data and surveillance activities related to both fatal and non-fatal overdose, and also providing training and or technical assistance to tribes in their areas on overdose data, epidemiology, and surveillance. in addition to that, techs do have the ability to explore data and surveillance related to the primary prevention or protective factors of overdose during this funding cycle. The Tribal Overdose Prevention Program is a supplement to the Public Health Infrastructure Center's new Strengthening Public Health Systems and Services in Indian Country Umbrella Cooperative Agreement. And so this program is designed for tribal communities to heal from the overdose epidemic by developing a comprehensive and culturally based approach to preventing overdose. And so activities for this program include community-based and cultural interventions to enhance protective factors against overdose, to improve overdose data and surveillance at the local level, health systems and public safety partnerships and interventions, and then other innovative community-based strategies that may not fit under one of those other buckets. We do also fund 3 supplements that address overdose prevention through public health infrastructures, Strengthening Public Health Systems and Services through National Partnerships Cooperative Agreement. So we are working with the National Network of Public Health Institutes, and through them with the 7 Directions Indigenous Public Health Institute to provide training and technical assistance to tribes and tribal serving organizations on overdose prevention. So over the life of this project, they've developed several products, including 2 environmental scans and a report on promising practices for overdose prevention throughout Indian Country and Alaska. They've also developed a diversity toolkit that provides tailored resources for supporting tribal and urban Indian community members who might also be members of LGBTQ two-spirit communities, youth, elders, and veterans. And they've also led the development of the Indigenous Evaluation Toolkit and are providing training and technical assistance to Injury Center funded overdose, suicide, alcohol impaired driving, and older adult falls prevention recipients. We're also funding the National Indian Health Board to implement an overdose prevention track at 1 or more national conferences each year. And we're also working with the National Council on Urban Indian Health on a 1-year project to learn more about the current landscape of overdose prevention in urban American Indian and Alaska Native communities. And we hope that this project will help to identify some current overdose prevention initiatives in urban communities, identify specific needs that urban Indian organizations have related to preventing overdose, and also identifying unique protective factors within urban communities related to preventing overdose. And the next slide is just a list of our currently funded partners. I know that that's a little bit hard to read, but with our Tribal Overdose Prevention Program, we are funding 16 total partners, 6 tribal nations and 10 tribal serving organizations. We're also funding 10 of the 12 tribal epidemiology centers through the Tech Fee Supplement. And those partners that have the asterisk listed there on the slide are partners that are receiving funding under both of those funding streams during this funding cycle. Next slide, please. So in addition to overdose prevention projects, the Applied Sciences branch in the Division of Injury Prevention is also funding 3 tribal initiatives. The purpose of the Tribal Suicide Prevention Program is to identify, implement, evaluate, and improve holistic community-based interventions that increase protective factors and reduce risk factors for suicide in a culturally centered way. The purpose of the Tribal Alcohol Impaired Driving Prevention Program is to reduce injury and death related to alcohol impaired driving in AIAN populations by implementing interventions using evidence-based strategies and indigenous approaches. And the Elder Falls Prevention Project is intended to improve capacity within tribal communities to develop, implement, and evaluate evidence-based, clinical, and community-linked fall prevention strategies. The ultimate goal of that project is to incorporate clinical fall prevention as a routine part of clinical care for tribal elders, and also apply tribally driven community strategies to support that clinical implementation. One upcoming project that's not listed on this slide from the Division of Violence Prevention, also in the Injury Center, is that in 2024, CDC will be funding up to 10 tribal sexual assault coalitions to implement and evaluate evidence-informed and Indigenous knowledge-informed strategies that address sexual violence and Indigenous determinants of health across Indian country. So this will be a 4-year grant that will begin in June of 2024, and the maximum funding amount for those funded coalitions will be $90,000 per year. Required activities include building infrastructure for sexual violence prevention, working with state health departments to develop or enhance a state or territorial action plan, implementing community and societal level sexual violence prevention strategies that promote health equity, and using data to inform prevention strategies. So this project has been published. I don't have any additional information, but if you do have questions or would like any more information, we can link you to our colleagues in the Division of Violence Prevention. And with that, I'll turn it over to Stacey to talk about Indigenous evaluation.
Thank you. It's good to be back. This is my third TAC meeting in a row talking about Indigenous evaluation. And so hopefully with each time, you're getting a good idea about our progress. And Jason was joking that if you invite one of us to speak, we both need to show up. And the other joke that we tell in the beginning is that he's the program and money guy, and I'm the scientist evaluation person. And so between us together, you get one solid public health professional. And so that's hopefully what you're getting from us today. And so for this section of our talk, I'll share a little bit about background context. We were able to present to the TAC at both meetings last year on the development and plans for the Indigenous evaluation approach. And so we're back again to tell you how that's going. So I'll provide a little bit of context. I know that there are new folks with us on the TAC and also in the room and on the telephone. And so I'll provide a bit of background on that, a very little bit of background, because our focus today is really to learn from you all. But if you'd like more information, wave me down after, drop a note in the chat. We can get you my email address. And this is my favorite thing to talk about, so you should hit me up for a conversation. If I don't give you the information you need today. And then I'll also provide a progress update after we talk a little bit about context. And we're in a very different place with Indigenous evaluation than we were last February when I was in this room, sort of letting people know what was going on. And so even though we are, advanced a whole year from there, it still also feels very much like we're in the beginning. And so I think you'll probably pick up on that as part of the talk as well. And through that, we'll talk about progress at two different levels. And so it's not just the progress that's happening in Indian country on the ground with our tribal partners and tribal organizations and the way that they are implementing Indigenous evaluation, but there's also stuff that has to happen internally as well, where we sit in the Division of Injury Prevention. And we'll talk about sort of our progress with that as well. And we will take a look ahead about what's to come, because we were talking earlier today about that 5-year funding cycle, and we're almost through year 1. So we've still got some time ahead of us. And may I please have the next slide? Thank you. And so for those who may have not heard us discuss DIP, Division of Injury Prevention's Indigenous evaluation work before, we're moving away from requiring sort of CDC-centric Western approaches for both injury prevention programming and also evaluation science. And we're doing this for 2 reasons. We're doing this out of respect for Indigenous knowledge, and we're doing this out of respect for tribal sovereignty. And so I would like to brag a tiny bit that we started this work before the guidance came down from the Biden administration on building Indigenous knowledge into federal programming and projects. And also the tribal self-determination executive order that came down a couple of months back. That's something that we've been pretty focused on even before that came down. And so we wanted to brag a little bit about it. We're not going to break our arms patting ourselves on the back, because there's still so much work to do. But we did want to note that. And we also wanted to note that Dr. Sample and also Ms. Russell, you had each asked earlier today about how this is happening sort of at an agency level. How are we leading into this guidance? How are we operationalizing that executive order? And I just want y'all to know that we are not representing the agency in that. We are talking about this little pocket of people nested very deeply, and sort of that's where that's coming from. So not representative. So we heard yesterday from this group about the ways tribe know their history, circumstances, and needs best. And someone brilliantly reminded us yesterday that tribes and CDC agree on the outcome. We do. Everybody who's in this room, everybody who's on the telephone, we all agree that we want American Indian, Alaska Native people to be healthier and safer. We agree on that. That is a monumental starting point. But going about that looks a little bit different. It looks a lot different from the way that we work through state health departments and local health departments. And I also want to note, in providing a bit of context, is that we have a deep and valued partnership with the team at the Seven Directions Indigenous Public Health Institute at UW in Seattle. And we are almost 6 years in working with the team at Seven Directions, and they're about 6 years into working with our overdose prevention partners. And that means a lot. There's a lot of learning, mutual learning that's taken place sort of among and between us. And so I wanted to provide that bit of context, and we've got their name on the slide because they really deserve the credit. So again, we're not going to be too busy patting ourselves on the back when we know we have really been led, not only from our partners at Seven Directions, but also our partners who are funded to do this work at the local level. So at the request of our partners at the local level, Seven Directions developed an Indigenous evaluation framework for tribal overdose prevention. And then they developed a toolkit for community-based tribal partners to use in grounding their approach within unique history, context, values, knowledge, and needs, and building their programs and evaluations from there. And so again, this is a departure. I've been working in public health a long time, and this isn't the CDC vetted evidence-based package that needs to be implemented and tracked using the set metrics at all. It's the opposite. It's building on Indigenous knowledge, it's leaning into sovereignty and building public health approaches up from there. And we've expanded that through the funding that Jason outlined. It's not just focused on overdose now, it's now crossing tribal suicide prevention, elder adult falls, alcohol impaired driving, and so forth. So I shared a good bit about that toolkit. It was released February of last year. So it's been in the field for a year, and this range of funding that we shared with you earlier, this is the first time that this has been formally offered to tribal partners in the field. And so those Seven Directions has done a great job disseminating it through their networks. So TASA has helped us. We've had a big dissemination push, and we've reported back to y'all on that. This is really our first effort to roll it into funding to tribes. And so we're really happy about that. And it's the first time. So it's experimental and we're learning a lot. And so we're really happy to sort of keep you looped in and to report on that. Their original design was focused on overdose. They right now are also developing a version of the toolkit for suicide prevention. And they're also working on developing some different more usable formats. So things that fillable forms for worksheets and things like that, that we hope will be more practical to folks who are doing the work. And so instead of striving for fidelity to a Western model that CDC is requiring, our partners are now able to operate with fidelity to their own communities, to their own values, according to their own needs. And may I have the next slide, please? And so the update. And so for those of you who have not seen 7 Directions Toolkit, there's a QR code there for you. You can also find it on their website. They've got a whole bunch of great resources on their website, or you can ping us in the chat and we'll get it to you. And one of the important things about this toolkit, and we got this from 7 Directions, is that it's optional. So that's something else that's new in this round of funding, is that we're not requiring any specific model or toolkit. So we understand the variation that's coming in from Indian country. We have tribes that are highly sophisticated and well entrenched with a clean, well-oiled machine to pump out Western evaluation. And if that is what that tribe wants, we are here for that, and we'll provide them evaluation support as they need it. We also have heard from tribes that they really want to lean into a more Indigenous approach, and they would really like some tools. And so this is offered for tribes to take what is of use to them, but it will not be required, because again, that would lean into programmatic and evaluation sovereignty. And so it's an offer, not a requirement. So what have our partners been up to across this program, all the programs that Jason outlined for us? They're on a similar timeline. And so if you, on the slide, we've got, the quarter from the last quarter of 2023, that is when our partners across the programs were, hiring staff, meeting TA providers from CDC, and really kicking off their first year. They're also reworking their work plans. They had a real skinny minute to apply for that funding, and now they have their first year to really dig in and rework their work plans. And if they would like to, they can build that Indigenous approach into what they're doing, and that may not have been in their original design, and that's totally fine. So 7 Directions held the first training for the sort of blended cohort of tribal partners in January, and we got a lot of really good feedback from our partners on that. And that TA opportunity serves as sort of a part 1. And so we've got coming up next month, we're super excited. Our partners are coming to Atlanta for a few days. And so we're going to convene everybody, meet everybody in person for the first time. And there's going to be a full day of Indigenous evaluation capacity building. And during that day, we will have a tribe present that has really done this operationally in a clear and experienced way to sort of share, because it is a shift in the way that we work with our partners. And so we have a tribe in mind that could, lead others through that process. And then we've got some workshop sessions as well that will build upon what 7 Directions has started. And then we'll have ongoing TA. We'll have monthly calls with us. My evaluation officer colleague, Brittany Carter in the back. We also have our team of technical monitors on the tribal support team for the opioid work. And so that technical assistance will be ongoing as well. And may I have the next slide, please? Great, thank you. And so now we'll talk about what's happening on the inside. And so, it's a major culture change, right? I mean, to most people who are involved in this feels different. This is like a different kind of relationship with CDC. This is a different kind of opportunity. And some of our partners are a little bit like, what? You're not telling us what to track? So we're definitely having those moments, and it's a culture change. And not everybody understands that yet. And so even internally within CDC, we're doing a lot of sharing of information and trying to sort of help people along. And so it's not as though we can, simply offer an Indigenous evaluation toolkit and call it done. We have successfully made this transition. It's actually just the very beginning. And if we were to disseminate this toolkit to our partners and not look internally at our own processes, at our own requirements, we're setting ourselves up to require something that actually could violate tribal sovereignty, that could actually, violate data sovereignty. And so we're really having to do the hard work internally as well. And So we're shepherding our sort of internal cultural change as we do this work too. And the first really opportunity to do that was in building the work plans for the supplements that were just published for all of those folks who just got funded. And it was a learning process. Different units within the division had different depth of understanding of Indigenous approaches. And, you know, we're a body of Western trained scientists. And so it's a process. But that's one of the big things that we're doing is we're working on capacity building within our own ranks to understand this process, to align ourselves with sovereignty and Indigenous knowledge. We're also learning from current tribal partners about Indigenous evaluation uptake and implementation from year to year. So we're highly engaged, having monthly calls, looking forward to having visits with them on site visits and also bringing them to Atlanta. And we are using that learning as we design future funding opportunities as well. And hopefully we're increasing our responsiveness to tribal input as a value of the tribal team and the evaluation team as we work with tribes. And part of that is coming here and being accountable to all of you, letting you know what's going on, asking for the correction if you see one that we need to make. And developing TA tools and supports with tribal partners. All of this came out of requests from our partners. This wasn't something that we dreamed up on our own. This was a response to requests for technical assistance and training on Indigenous evaluation approaches. And then the bottom one is lofty because it really is a shift from the way CDC tends to do things. And that's developing presentations and publishing papers with and not about our tribal partners to advance tribal injury prevention at the federal and tribal levels. That's something we're real guilty of, is having teams of people inside CDC publish articles without any tribal input at all. And that's something that has been a very hot topic since we have been here just yesterday. And so that's something that just for our programming at least, that is a goal for us to keep that from happening and to really build meaningful partnerships where those collaborations happen organically and not as they tend to. And may I have, I think, my last slide. Thank you. And so this is just ongoing. So we are sort of 3/4 of the year through year one. Looking ahead to year two, we will continue with our monthly calls. We will continue with our site visits, peer-to-peer engagements with our recipients. And we are really watching this process closely because we're hoping to learn because it is new and it is different. And we still are feeling baby steps to us still. So we're really counting on tribal partners' feedback. We're building that into our connections with them on monthly calls. Also, when we have folks here next month, we're going to get to see work plan revisions at the end of year one so we can see what was proposed for initial funding. And then we're going to see through this process of technical assistance and engagement, how has the work changed? Have they been able to build more of the cultural values into the work? Are they exploring metrics that are actually more culturally relevant? And so it's a question, we don't know. So we're happy to sort of learn from that process. And we will also, we're engaging our partners in a conversation in March about performance measures. Again, something that tends to be standard issue from CDC. Here's your spreadsheet, fill it out, get us back. We've heard overwhelmingly that when we do that, we often burden our partners with data collection of elements that don't have external validity. So they're not important to the people who generate those reports. And so we've heard that, and we're starting a conversation in Atlanta next month. We would like to know from our partners, is there a way? Yes, CDC needs to understand what's going on. Yes, we want to go to bat. We want to make the case for the programs and make the case to build and grow. And to do that, we need information. But we don't want to be requiring information from a community that may not have the capacity to pull it together at that time. We don't want people gathering information that actually doesn't measure what's important. And so we're starting that conversation and we'll let you know how that goes. It's emergent. Again, a learning opportunity. And we will having, just our internal engagement sort of within CDC as well, within the Division of Injury Prevention, as we all sort of learn how this process can move forward. And so with that, it's back to Jason.
Thank you, Stacey. Next slide, please. So, as exciting as it is to kind of talk about, some of the work we're doing and share with you some of the work that we're doing. And again, we're only 6 months into these new kind of funding, these projects and funding cycle. We really are already thinking about what the future of injury prevention and overdose prevention looks like in tribal communities. As this kind of process and ideas evolve, we do plan to conduct, both listening sessions and official tribal consultation at the appropriate time, although we don't know exactly when that's going to happen yet. And so as we're kind of thinking about the future, if you could go to the next slide, please. I think it's really important for us to acknowledge some of the barriers that, tribal nations and tribal organizations face, kind of related to, I think, both applying and receiving federal funding. And I was really happy to hear Dr. Cohen acknowledge and talk about some of those barriers yesterday during her talk. I think what's listed on the slide here is kind of just based on our experience over the years working with tribes and tribal organizations. It's what we've learned from interacting and engaging with the TAC over the years. So, this isn't intended to be an all-inclusive, sort of list of barriers that tribes and tribal organizations face related to federal funding. And they're also not specific, of course, to the injury center. I think these apply across not just the agency, but, really to all federal agencies that provide funding to tribes. And then, if I'm being totally honest, Stacey and I really aren't in a place to make major changes like to some of these barriers that are listed here. But I think in the spirit of trying to be a good partner, we really do want to learn more about these barriers. We want to try to hopefully overcome some of those barriers where we have a little bit of control. And of course, we want to be an advocate for you all, within the agency and trying to overcome some of these larger barriers. And so, we've heard how burdensome that the federal, application, funding process can be. We've heard about how limits to overhead or indirect cost can really be a barrier to tribes and tribal organizations. How, some tribes or tribal orgs have, limited time or personnel capacity for program planning, for evaluation planning. We've heard lots about the burden of reporting. And that is something that we have tried to change a little bit, at least internally, which I think Stacey also mentioned. And so this is, I think, a great segue into the real reason why we're here, which, there is a question listed here, which is, are there any other barriers that we're missing? But we really are here to kind of learn from you all about not just barriers, but if we could transition to the next slide, just some other questions about how we move forward in our injury prevention and overdose prevention funding for tribes.
And so we're breaking all the rules about the number of words on a slide, but y'all have this list of questions in your packets. And so we just wanted you to sort of be ready. There's a list of questions here. Well, as Jason said, we would love to learn more about the barriers. If there are barriers we're not tracking to applying for CDC funding, we'd love to know that. Any recommendations you have for reducing those barriers. We'd like to know what types of questions we should be asking to learn more about preventing injury and overdose in tribal communities. What advice do you have for conducting successful listening sessions and tribal consultation? We know that this is elemental to beginning anything new. And we're looking for advice in this process as well. We'd like to know if you have any initial thoughts or suggestions for next steps in the injury and overdose prevention portfolio. You've seen the body of it today. And so if there are additional things that you'd like to suggest, we are absolutely here for that. And then we know that in the past in TAC meetings, there have been questions about mechanism for the way that we fund our injury prevention work. And so we'd love to know your thoughts on the tribal umbrella versus an injury-specific cooperative agreement that funds tribes directly. We'd really like to know your thinking on these things. And so I think what we'll do now is stop talking, turn off the mics. We've got folks taking notes, and we would love to hear some discussion and ideas that you have. Thank you.
Thank you, Commander Hymer and Ms. Willocks, for delivering an insightful presentation on Division of Injury Prevention funding for tribes, updates and plans for future funding. I invite all TAC members to provide their feedback. Your input is highly valued, so please feel free to share your questions or comments. Be sure to, if you're virtual, be sure to raise your hand. And if you're present, be sure to speak into your microphone, give your name and the area that you represent. So the floor is open for discussion. Yes, Ms. Frias.
Hello, thank you for your presentation. I have a question about the difference between the Division of Injury Prevention and the Injury Center. Because I was trying to find your information on the CDC website. So I was trying to find the evaluation. And then I was trying to find your information, but I can't find it. And what I can find is the Injury Center. So is it the same or is it different? Because you talked to, and I'll go a little bit further because it's very narrow, the information that you talked about with the overdose and with, some of the things that with the overdose and with the, some of the things that are funded under with the overdose and also with the alcohol impaired driving prevention and the elder laws. So those are very narrow. But when I look at the Injury Center, those are the types of programs that I was interested in looking at also, with particularly with the impaired driving in general, with young drivers and elders, and also with bicycle safety and transportation and a lot more things. So I was trying to connect with the Injury Center and what you're talking about here. So can you help me out with that?
I'll try my best. So the Division of Injury Prevention is one of 3 divisions under what we call the National Center for Injury Prevention, or in shorthand, we say Injury Center. There is a tribal specific page. I honestly, right now, I know there's a little bit of transition with our website. We can make sure that you have the links, at least the links that are currently available for our programs, knowing that that will look a little bit different in the future. But we can make sure that you get access to those. So the Division of Injury Prevention is one of the 3 divisions in the Injury Center. So there's also a division of overdose prevention and the division of violence prevention. And those 3 divisions make up the entire Injury Center.
Okay, and so you'll give us that information. So do you coordinate with the Injury Center? Or that makes up? I'm still confused, or maybe I'm just tired.
No. It's been a long couple of days.
Yeah.
No, so we are under the umbrella of the Injury Center.
Okay,
Right.
all right. Okay, thank you.
You're welcome.
Ms.
And then the
Stanfield?
evaluation.
Yeah, and I just wanted to add about the evaluation. So you will not find it on CDC's website, and that's purposefully done. And so that the Indigenous Evaluation Toolkit sits on 7 Directions Indigenous Public Health Institute's website as their intellectual property.
Okay.
And we did that for 2 reasons. Number 1, it's their intellectual property. And number 2, we feel that it may have more legitimacy living on an Indigenous Public Health Institute website, and it may increase tribes accessing it. And so that's where that is. And again, we can get that link out to you as well.
Okay, thank you.
You're welcome.
Thank you for your presentation, Sharon Stanfield, Rep at Large. I can tell you're both very passionate about the work you do, and just as tribes are, and the work that you shared with us today about overdose, suicide prevention. You can imagine that for us, this is injury prevention is right at the top of our needs and our tribe's goals are for our people. And so I just want to thank you for the work you do. And number one bullet there you have is how to reduce the barriers to funding tribes. I noticed that 5 tribes were funded in that first group that you showed us. And a lot of techs, health boards, councils, who I'm assuming tribes are getting services through. But there were only 5 tribes that were actually funded. And I just want to restate, as I did yesterday, that the executive order of the president, maybe I said it today, it's been a long day. We need to have funding that's more accessible and flexible. This is like and for some tribes, this is the number one health need they have. A need is injury prevention. And when you look at suicides and you look at the epidemic that we're in right now and how we're focusing our attention so much in this, we're losing our children. We're losing all across the spectrum, tribal members who are in pain, who have some real needs to be met. So this work, we need to make sure we have accessible, flexible funding that needs to come through our compacts and contracts, if that's how a tribe chooses to receive it. We recommend no grants. We just recommend the funds would come directly to us. I know that's going to be a logistic nightmare probably for you, but that process doesn't work for us. And so I just want to really, if you're really going to think about reducing barriers, I would say that that's where you need to start, is with that executive order, working with the CDC in your system on how to respond directly to removing these hurdles of grants so we can receive funding for this valuable work and all the work that you folks have been doing. Thank you.
Ms. Russell?
Thank you, Ms. Barker. And thank you, Dr. Stanfield, for kind of segueing the conversation for me. Kim Russell, Director for the Navajo Department of Health, Navajo Nation. So I just confirmed with my EPI director, and for the ages of 10 to 59, for my community, unintentional injuries is the leading cause of death. Leading cause of death. I don't believe we have any funding from CDC, although we are doing, different things to address it. But again, for my nation, for the ages of 10 to 59, the leading cause of death is unintentional injuries. I'm going to go back and see how does that break down? But just being a part of my community, I know largely it's going to be motor vehicle accidents. Of course, some of them resulting in a traumatic brain injury, suicide. And one that I was kind of just recently informed of that I really didn't think about until it's like, yeah, that makes sense. But we have community members that freeze to death during the winter. And that was interesting to me. I didn't know that, but it was because I had a staff member who worked for state government, and she would go through the death certificates, and she goes, I always saw freezing to death as a cause of death for Navajo. So, Director Dolphin, I'm glad you're here. And I think some of these issues that we talk about really requires a multi-pronged approach to address some of these things, right? One of my fears is really being in a car accident for my whole family, because it's just so common for that. And I noticed, of course, the Tribal Alcohol Impaired Driving Prevention Program, 125,000, one recipient, right? I also want to talk about how there's other things in regards to, at least on my nation, we're very rural. We lack a lot of infrastructure. Just from the house that I live in, tribal housing that I live in, to my road, I was like, because that is filled with potholes. And every morning I'm like, oh my God, when are they going to fix these potholes? Right? But it helped me get my frustration out. So I saw that as a positive, but that's just commonplace for my nation, is to have pothole-ridden roads, which become very unsafe. a lot of unpaved roads. Another thing that really gets me upset when I go home is that our roads are not marked. They're very faded. So when you drive through a 5-lane highway, like in my community, right across from a high school, those roads are not marked. So when you're going through at the nighttime, they're non-existent. So I guess my point being is, how do we approach this with other departments within federal government? I'm not part of our transportation department, but gosh, the things that I wish we could maintain our roads. I wish we could have access to healthy foods. Those are the two, and access to housing. But that's not within the kind of the housing or the health realm, right? But we understand that these three overarching big areas of really promoting and creating a healthy community, that's what you need to really impact the work that we're going to do. So, I take that approach with the work that I do. I try to work as closely as I can with my other directors of my nation, our Department of Transportation, housing, just, the whole lot. But again, going back to injury prevention, I know that, within CDC, what you can do is here, but we're really having to kind of go out and, work with other sectors of government to really address some of these things because, until we can get our roads paved and safe, it's going to still be, what is it called? Not injury prevention, but the other term that came out. I can't remember the term, but it's like reducing the risk or reduce harm reduction, right? But that's kind of what we're doing right now. But anyway, just wanted to mention, those statistics that we have for our nation, that the leading cause of death for my people from the age of 10 to 59 is unintentional injuries.
There wasn't a question, but I do want to make a comment because one of the things that is coming out of this is the need for us to be thinking a little bit more broadly about how we work in the interagency space and particularly outside of HHS. That's not an approach I can say, quite frankly, that we have, at least in our center, have spent a lot of time doing. We have pockets that work with, for example, our Division of Partnership Support works with the Department of Interior on some activities. But I haven't seen a really focused effort on, as you put it, a multi-pronged approach that involves the interagency outside of HHS. And I think this is something we really need to bring back. So I appreciate the comments. We're having some really great discussion here today. And thank you to our presenters. We want to be respectful of time, right? We have gone over for this and we want to stay on schedule. So we're going to thank you for your presentations. And if we have any comments or feedback additional that we want to provide to this group, we'll certainly make sure we get them back to the group. Does that sound good? Right. Okay. All right.
Okay, thank you once again for a great presentation.